Hello, everybody. I am Dr. Raktim and I am here to discuss a very important topic of cancer registry. This topic often comes as a short note in our theory examination. Let us discuss about the cancer registry. It is very important both for our theoretical and as well as practical knowledge, like how cancer patients are registered and where are they registered, how is the data compiled and how is it analyzed and what importance does it hold. So let us begin the topic of cancer registry. Coming to the introduction part, cancer registry comes under India's flagship program of surveillance named the National Cancer Registry Program. It was launched by Indian Council of Medical Research in the year 1981. Now, it is coordinated by the National Center for Disease Informatics and Research, which is located in Bengaluru. This is the background. This photo depicts the cancer registry. So, we will be seeing how these data are collected, compiled. Let us go on to the next slide with this background. See, this photo gives a diagrammatic representation of how cancer registry works. The first step is the collection of data. Here, the identification of cancer patients are done from multiple sources. So basically here, in multiple sources, I mean it can be population-based cancer registry or it may be hospital-based cancer registry. What are these? We will be seeing this in subsequent slides. For now, you remember that the identification of cancer patients are done from population or the hospital. That is the first step of collection of data. After collecting the data, there comes the registration of those cancer patients. Here what happens that there is a systematic recording of all the information of cancer patients: the name of the patient, the age, sex, occupation, education, their complete postal address, what is the type of cancer, how is it diagnosed, where it is diagnosed, when it is diagnosed, and what is the treatment protocol. Everything, these data are captured in the registration part. Now, after capturing all this information about a particular cancer patient, then the compilation begins. This compilation may be in the level of a hospital if it is hospital-based cancer registry, or it may be in the level of population where it is population-based cancer registry. All these databases are compiled and collated. After compilation of these data, it is then analyzed and interpreted. What is the analysis we make here? The analysis that is being made is what is the prevalent type of cancer in the community or in the hospital or in the concerned geographical area from where the data is collected. That we will know about it, the incidence, the prevalence, the trend analysis of cancer, then what is the survival trend, the mortality and the morbidity patterns of cancer. All these details we will be getting to know about after analysis and interpretation of the data. After that, this information is disseminated to the authorities. The information that is disseminated after analysis and interpretation is on what cancer to focus on. What is the programmatic approach that can be taken to reduce the burden of cancer? All such decision making and information sharing is being done at the level of dissemination. And accordingly, the budget is sanctioned and the control activities and strategies may proceed further. This is in a nutshell about the cancer registries that is being done. Now, going into the depth of this topic, what is the purpose of cancer registry? As I have mentioned it in my previous slide, it generates a reliable data on incidence, prevalence, mortality, morbidity, patterns of cancer in India. Thus, it provides a scientific evidence in the planning of cancer prevention, early detection of cancer, and framing strategies to control the various types of cancer. This is the main purpose of cancer registry. Coming to the objective now. Since I have mentioned that these data is reliable, so it provides authenticate and systematic information on cancer burden in India. We generally tend to say that the northeastern India have a high prevalence of uh, throat cancer. How and what is the uh, main reason behind it? All these things we would be getting after analysis and interpretation of the data from the northeastern India. Similarly, when we say that the cancer on the lip and oral cavity is most prevalent in the northern part of India, why is it so? What is the reason? That we will be finding it from the cancer registry from the northern India side. So this is the first objective of cancer registry. Thus, it helps in supporting the health planning, health management, research, and cancer control initiatives of a particular defined geographical area. So the purpose and the objective mostly overlap by providing the reliable data, and this data helps in proper planning activities. That is the main crux of the objectives of cancer registry. Now, coming to the types, since I have mentioned it in my second slide, it can be population based cancer registries and it can be hospital based cancer registries. Few points on population based cancer registry now. The population based cancer registry, as I have mentioned, it collects data from the whole population. So it collects data of new cancer cases arising from the population. How and where is it collected? See, when a patient who is a probable suspect of a cancer, that patient from the population will come to a particular hospital. That person may come to some other private clinics or treatment facilities, or they may come to uh, pathology department, biochemistry department, radiology department. So all such uh, health facilities, when they suspect a particular cancer along with their reports, these patients' details are then compiled and collated in a central cancer registry in their database, and it is password protected in a computer. In this central cancer registry database, this information is being captured about the particular patient from the population. The main thing here we have to understand that the complete postal address of the particular patient is being recorded for further evaluation and revision. So how does it help us? It helps us in estimating the cancer incidence and prevalence from the community. It gives us the mortality and survival trends. We will get to know about the 1 year survival or mortality statistics of that particular cancer. We will get to know about the 5 year survival rate of that cancer. So all such things we get to know from analyzing this population based cancer registry. The main thing which we know is the incidence, because we are collecting new cases. That is very important for us. Secondly, as I mentioned, the survival cancer trends we will get to know, and ultimately the public health planning, management, coordination, research, and cancer control activities can be taken up after analyzing this data. Same thing, I have written it in a point form when I have said what is the outcome. We will get to know about the changing trends of cancer with its causes. It will help us in framing strategies for resource allocation, and various cancer prevention programs are functioning. How is it functioning? Where we have to invest more, where we can cut short our budget. So these questions are being answered from this population-based cancer registry. This diagram represents in a very schematic way that can be reproducible in the examination as well, that how population-based cancer registry works. This was all about population-based cancer registry. Let us come to the next registry, that is hospital-based cancer registry. Here what happens that when a patient, suspected cancer patient, comes to you in a hospital and with certain reports, that patient is diagnosed of cancer, that what happens that the hospital, it is the responsibility of the hospital to collect all the detailed information of that particular patient and keep it in their hospital records. So thus they collect data on all patients of who are diagnosed or treated for cancer in their specific hospital or cancer center. Thus, I want to highlight that when we say population based, it is from the whole population. We generally tend to give more focus on that, on the postal address and the location of the particular patient. But in case of hospital registry, we tend to give more focus on which hospital, from which hospital the particular cancer patient is getting diagnosed or treated. Thus, it gives a hospital data of how many number of cancer patients they are treating, they are on treatment, they have completed treatment, and or they are diagnosed. So the main objective is it helps in improving the patient care and track the hospital clinical performance regarding cancer. So thus to maintain the quality standards of a particular hospital, the hospital-based cancer registry works. It is the duty of the chief of the hospital, which is generally the superintendent of the hospital, to maintain this hospital-based cancer registry under his guidance. And thus, it is the duty of the chief to allocate and further plan and progress the cancer treatment strategies for that particular hospital. In my next slide, I will be giving a schematic diagram. It will be more or less similar to population-based cancer registry, but few nuts and differences I will highlight it. Let us go on to the next slide. The outcome is the similar. It helps us in the tracking of the patient care over a period of time. The patients who have come to the hospital and getting diagnosed or treated with cancer, it helps us in tracking the patient. Like I said, it helps us in maintaining and knowing the quality of the hospital performance. To evaluate the performance, it is important to know about the cancer data registry that is being recorded in that particular hospital. And like I said, support and promote research activities on cancer, it may be taken up from the hospital. It is generally taken up in a tertiary care cancer institute where postgraduate training is being provided and super specialty training is being provided to the candidates. So let us go on to this schematic diagram. As I have said, when a patient uh, comes to a hospital and when the hospital suggests some reports and after getting suspected with the cancer, how it works, the patient is visiting the hospital. This is the inpatient, patient in, and after suspecting, the patient is getting admitted. The patient is subjected to various tests. It may be in the pathology department, it may be in the diagnostics department of radiology and imaging, it may be from the oncology wards, okay, and it may be from different departments of surgery. After getting a surgery done, a sample is sent to biopsy and all. So all such um, delivery points for the hospital for a particular patient is there, and they will send some samples, and when this sample and the all the evidence suggests that the patient is having cancer, that particular record is being maintained in the hospital medical records, which is sent to the central hospital cancer registry. In the population based, it was the central cancer registry of the district or the state. Here in case it is for the hospital. It is maintained in the database of the hospital, and this hospital data is being analyzed and interpreted, and same things we will get to know is the percentage of cases treated for cancer, what is the prevalent type of cancer patients coming to the particular hospital, what is the trend analysis, what is the survival rate, and how much is the mortality pattern of that 1 year, and what is the 5 year survival rate. All such things we will get to know. What is the staging on in which the patient is coming to that particular hospital, how effective is the treatment, and all such various informations we will get to know after analyzing these hospital records. And this will help in planning the resource allocation, the manpower, the budgeting, the coordination of cancer activities taken up by the hospital. So all such things are the outcome of this hospital-based cancer registry, and thus it will help in improving the quality of care provided to these cancer patients. So the main crux is the information generated in a population-based cancer registry and hospital-based cancer registry are almost the same. In a hospital, it was mainly focused on a particular hospital, and in the population, it is mainly focused on the bigger geographical area. That is it. Let us now come to the significance of these cancer registries. The main significance after all these discussions, it is like to generate reliable data and to estimate the regional and national burden of a particular cancer. This will help us to identify the most prevalent cause of cancer, what is that, which cancer is more in which geographical area or in the nation, and what and how are the strategies we have to focus on. Since I said that the geographical variations can be identified, similarly, the high risk groups can be identified after knowing the reason or causes of that particular cancer. After knowing the high risk groups, after knowing the causes of that particular cancer, there would be a supporting evidence for cancer control strategies. We will get more information on how to control that particular cancer. This will help us with our data. So it will help in assisting the planning, screening, diagnosis, and treatment, and preventive and palliative care services as well. Lastly, I want to highlight that the cancer registries help in trend analysis of the cancer incidence and mortality. I have discussed it repeatedly in my previous slides that trend analysis of a particular cancer can be determined with these cancer registries, and thus it supports the epidemiological and clinical research activities. That is all about the significance of cancer registries. But here I want to highlight is that uh, it is not easy how we are discussing it. There are a lot of challenges that we face in cancer registries, and these challenges are those that helps us to grow. So these challenges, if we overcome them, we all will be able to overcome the burden of cancer. So let us discuss few points on the challenges of cancer registries. Number one, there is uneven geographical coverage of registries. In India, it is a vast country, and all the geographical areas do not have proper cancer registries. Because one or the other reason is there for which the cancer registries are not done uniformly. Few of the places are doing very good, and few are the places where the cancer registry data is not at all present. So, due to the vast geographical differences and variations, it is very difficult to estimate the true cancer burden of the nation. There is also underreporting of the cases from rural and urban areas. Due to the various customs, beliefs of different communities in India, It is even important that uh, the places in India are like, if someone is getting diagnosed with cancer, that patient will somewhere remain aloof. They may isolate him or her. Secondly, the manpower and the staff to diagnose cancer, the facilities there may not be present. And thus, these are some of the reasons that I am citing for underreporting of cancer, but there may be many other reasons as well. But here we have to understand that the underreporting of the cancer patients is there in India. And there is a huge difference of in rural and urban areas as well. Thirdly, how the cancer patient's data is being collected, compiled, analyzed, interpreted is the main thing. The quality and completeness of data is not at all uniform all throughout India. These variations lead to disproportionate burden of cancer. Okay, the correct estimation is very difficult because of these variations. And to add to this, to add to this, I have to say that there is limited integration with the digital health information system. If everything goes well, sometimes the manpower shortage is there, or the logistics is not there, there is no internet connectivity, there is no mobiles or tablets, for which the digital integration of these cancer registries is not being done in the information system. And due to this, the records are not being kept properly. The records are lost. There would be missing data. And this integration limitation is the main issue. This is being taken up in the National Digital Health Mission to some extent, but this is an important issue in cancer registry. And lastly, as I have said, there is a shortage of trained personnel for cancer registration. There is inadequate training of the staff. There is even lack of manpower in almost all the places. There is lack of resources like logistics, computers, tablets, internet connectivity, okay? The remote location of a place where the cancer registries are not there, not set up due to lack of training, you can say. So all these challenges are there in cancer registries in India. How to overcome it? It is, I leave this question up to you, that how to overcome this. Please think about it so that we can make India a cancer-free country. At least the cancers that is due to our personal habits, or that can be modified or prevented. So how these cancers can be prevented, think upon it by overcome these challenges. That was all for today's topic. Thank you for patient hearing from my side. If you have any questions or queries, feel free to please put it in the comment box. I would be happy to answer it. Thank you.